by infiltrations. Now let's turn to cannulating the mature arteriovenous fistula. As with the new fistula, begin by assessing the mature fistula before every dialysis treatment. Look, listen, and feel for complications such as infection, stenosis, Steele syndrome, and aneurysms, and for appropriate cannulation sites. Let's view Dr. Bethard assessing a mature fistula in a dialysis patient.
So once you get some basic history about the fistula, the next thing you'd like to do is just identify the fistula. And as you can see, this is in his forearm, which means that it's probably going to be a radiocephalic. Here's the normal place for the anastomosis to be made, and you can see there is an anastomosis there. It's on the inferior aspect of his arm, so this appears to be a radiocephalic fistula. The next thing we'd like to do is just look at its overall appearance. Look at the status of the skin for any thinning of the skin, any evidence of ulceration or bleeding areas on the skin. Those would be very important to note. You notice he is getting two areas here that bulge. He has some modest-sized aneurysms, and those should be noted. The next thing you want to do is launch into the physical examination itself, and the important thing there is to be systematic and be complete. Sometimes you'll see an obvious abnormality, but there may be more than one, and you need to identify them all. The way I like to start is to identify the anastomosis. That's going to be the point of maximum thrill. The best way to feel of a thrill is with the flat part of your fingers or even the flat part of your hand. This part of your hand is often more sensitive than even the tips of your fingers. But as you feel here, we can tell that this is the point of maximum thrill, so that's where the anastomosis is going to be. And in feeling of the thrill, you'd like to focus especially on the diastolic component. The thrill should be continuous with both systolic and diastolic. As stenosis develops and resistance downstream increases, the diastolic component begins to shorten and eventually drop out. And with severe stenosis, what you'll notice is only a systolic component to the thrill. This gentleman has both a good systolic and diastolic. Then as we move up the fistula, this region, the region immediately adjacent to the anastomosis, the first 4 or 5 centimeters, we refer to as the juxta-anastomotic region. This is a common region for pathology. This is the region that the surgeon has manipulated in various ways in creating the fistula, and there's a tendency for stenosis to develop there. The way that can be detected is if you feel over the anastomosis, you'll feel a very prominent pulse. The thrill may be diminished, and then as you move upward, it seems to just drop off. Now he does have a little bit of an increased pulse here, and you can see here that there is a narrowing of the fistula in this region. That's not very marked, but it is mildly abnormal. I would think that in this instance, the important thing would be to correlate that with the flows measured on dialysis. It may be of no consequence, but that's the region looking for juxta-anastomotic stenosis. Then we move up to the body of the fistula itself. We like to feel for the pulse. There's a basic principle with fistulas that is this: pulse is bad, thrill is good. Pulse means downstream resistance, in other words, stenosis. Thrill means flow. So normally when you feel of a fistula, you would like to feel very little pulse. If you press too hard, you can induce an obstruction and create a pulse. So you want to feel very lightly, and as I feel here, I feel no pulse whatsoever. All I feel is thrill. In looking at this area, it's also good to totally occlude the fistula and feel of the occluded pulse. We call this an evaluation of the augmented pulse, or simply augmentation. And a fistula is said to augment well or not augment well. It's a test of inflow. And as you can see with this occluded, if you look at my finger, he has a very strong pulse. This fistula augments very well, which also would make me think that this mild narrowing in this juxtaanastomotic region may be of no consequence. While you're doing that, and as I say, that's a test for inflow, and if it augments well, it indicates that the inflow is good. Feel of the thrill with it occluded. Normally, if it's totally occluded, there should be no thrill. If one wants to look for an accessory vein, start by occluding the fistula low on the body of the fistula, feel for the thrill. In this instance, the thrill is gone because the fistula is occluded. Then you move up a short distance and repeat the process. Totally occlude the fistula, feel for the thrill. And in this patient, I feel a soft thrill with his fistula occluded. That means there's a escape pathway or a side branch, and often you can see them, as you can here. You can see that he does indeed have a side branch. You can also see that there's some veins down here. So there is either a collateral, which is pathologic related to downstream stenosis, or an accessory, which is normal anatomy, just a side branch as we all have. He does have this side branch. The question is it significant? And whenever you look at the overall fistula and feel of the thrill indicating the level of flow in the fistula, it makes me doubt that this is of much significance. There's three parameters that you want to evaluate in looking for areas of stenosis. You want to look at the pulse. Is it normal pulsation, which in a fistula should be essentially zero, or is it hyperpulsatile, which would indicate a stenosis beyond that point? You want to feel for a bruit or a buzz. Anywhere there is turbulent flow, you will feel a thrill. Normally, there should only be a thrill at the arterial anastomosis. Any other thrill is pathologic and indicates turbulence and some degree of stenosis. So, and then the third parameter is auscultation, listening for a bruit, which goes along with the thrill. Now, when you're looking at a thrill or a bruit, you want to particularly focus on the diastolic component. That's the component of that sensation or sound that occurs during the lowest pressure in the cardiac cycle. As resistance downstream increases, that diastolic component begins to become shortened and will eventually disappear. So if you feel the thrill and focus on the diastolic component and you feel a very good diastolic component, it would suggest that there is no stenosis downstream. The same is true for the bruit. Listening for the bruit. You want to listen to the pitch of the sound and also focus on diastole again. Normally, it should be very low pitched, a continuous bruit. At the other extreme in pathology, severe stenosis, what you will hear is the pitch will go up, diastole will drop out, and you hear a short, very high-pitched sound only. It's important whenever you're examining for those abnormalities to examine the entire extent of the fistula, identify the draining veins, and examine the draining veins. Because as you well know, areas of stenosis can develop in these veins that are draining the fistula all the way up to the central veins. And it's important to also feel of the anterior chest, to feel over the subclavian, over the cephalic as it enters this clavin, because if there's stenosis at that level, you may feel a thrill and hear a bruit as well, indicating stenosis to that point. And then a very useful test in evaluating a fistula is to simply take the patient's arm and elevate it over their head and see what happens to it. If you notice here, look how this fistula totally collapsed. It becomes flabby. If it's down in this manner, it's distended, very firm. As we raise it up, it just collapses, and you can see it has a very soft, flabby feel. That's normal. And when that occurs, it means that the flow in that fistula all the way up to the central veins, through the central veins, is open. If you have a stenosis, what will happen is it will stay distended peripheral to the stenosis and collapse central to the stenosis. If we were to summarize the findings of a stenosis within the fistula, what you would find is that the fistula peripheral to that stenosis is going to be distended, hyperpulsatile. The fistula proximal will be soft, easily compressible, and will collapse when elevated. At the point of stenosis, you will feel a prominent thrill with a shortening of diastole or complete absence of the diastolic component. If you listen, you will hear a high-pitched bruit with shortening of the diastolic component or complete absence. In this gentleman, what we find is that it's a radiocephalic fistula. He has some minimal narrowing in the juxtanastomotic region. He has an accessory vein draining here, but he appears to have a very good size fistula with good flow in the fistula, and he does not appear to have any evidence of pathology in his outflow or in the body of his fistula. So I would judge this to be an excellent radiocephalic fistula, one that should serve him very well for a number of years to come.
The assessment of mature forearm fistulas, as well as forearm grafts, should also include a monthly sleeves-up exam of the upper arm. The purpose of this exam is to identify mature outflow veins of the fistula or graft that might potentially be used for a future upper arm AVF should the existing AVF or AVG arteriovenous graft fail. If an upper arm vein appears to be suitable for a future fistula, note this in the patient's chart and notify the nephrologist and surgeon. You can find a sleeves-up protocol in Change Concept number 6 on the Fistula First website. Here you see an outflow vein, the cephalic vein, of a failing forearm AVG that is suitable for conversion to a fistula.